At the outset, let me thank the organizers for inviting me to give a talk on an aspect that I'm quite passionate about. India, as we all know, is a land of contrasts, where the urban slums are but high rises, where urban and rural lives are in complete contrast in many ways. This same contrast exists to the facilities that women birth in, and we can have the poshest of labor and delivery rooms to those facilities which are so overcrowded that women are sometimes without a bed and are on the floor. The cesarean section rate in India has gone up over a decade, and we know this map that compares the NFS 2005-6 to the NFHS 4 data, which shows that section rates have gone up to over 50-60% in many states in India. Now, the average rate in India is quoted to be 17.2, but it's a huge range, and you have rates of about over 50% in Telangana, 30% in Tamil Nadu on an average, but the urban rates are much higher than the rural rates. But I also want to draw your attention to the fact that when you look at some of the states, the rural rate is much, much lower than what would be considered optimal, sometimes as low as 3%. And this has led people to debate and argue about the Indian C-section quandrum, too many or too few, because it is both. And while we have been ashamed by this news clipping about a woman who lost her life in the pandemic, trying to access care in 8 hospitals over 15 hours, the fact remains that this access to care and need to go to multiple stops before obstetric care can be provided is there a reality in India, even outside the pandemic, where sometimes women have to cross rivers in spate to reach their provision for care. Now, the fact also remains that more than 50% of obstetric care in India is delivered in the private setup, and this could be either in the urban or in the rural area, because both have private care that is available. And the private care could exist in large, posh corporate hospitals or chains. It could be in charitable trusts. It could be delivered by small family-run units, which is the norm in many smaller towns. And it could be private teaching institutions, and the challenges in each of these places is different. So what is it that drives the rate? Is it risk? Is it request? Or is it litigation? Let us have a look. Now, I draw your attention once more to this graph, which shows us that the overall cesarean section rate in India has gone up. What has gone up in the private health facility is far higher than what has happened in the public health facility. And interestingly, women who access antenatal care more than 4 visits somehow seem to be at risk for a higher cesarean section rate. The odds of cesarean section have gone up from 1.62 to 4.17. And again, I want to reiterate that the color map has changed in almost all of India. And if you look at what may be the driving forces, the analysis has shown that the more educated the women, the households which have a higher wealth quartiles are the ones which are at higher risk for cesarean section. So what is it that drives the rates? Is it the obstetrician? Is it the woman? Or is it the system? And these are some of the articles that I have looked into, and I quote in the subsequent slides of my talk. So what are the factors that are at play? In the center of it all is the obstetrician, who is multitasking and who is often doing obstetrics and gynecology, and in many smaller private setups also running the place and looking after the admin. This is an interesting article which did a qualitative analysis talking to obstetricians in the private sector in Delhi. And 2 points that stand out are the cost of delivery and the time and the nature of the practice. So many obstetricians have quoted convenience and said that one normal delivery could cost them sometimes 1 or 2 nights. And if they do more than 15 deliveries a month, they may never be able to sleep at home. More importantly is the concern about decision making, because if I am awake for 2 nights in a row, then on the 3rd night, definitely my judgment is going to be clouded. And when one is alone, decision making sometimes can become challenging. There is the worry about legal action, and more recently, increasingly, the worry about violence and loss of property. The financial gains from a cesarean section are often written about, debated, spoken about. The cost of a cesarean section clearly is higher than the vaginal delivery, but it is not remuneration to the obstetrician alone. It is remuneration to the facility. And in the private sector, especially in many of the units where it's looked at as a business, definitely, because the incentive, financial incentive from a cesarean section is higher, hospitals are, not particularly troubled that the section rate is higher. There is no accountability to rates. There is a systemic issue as well, because even if you are in a high-end corporate hospital where all facilities are available for patient care, in such places, there isn't a dedicated obstetric OT. And therefore, when an obstetrician needs to take a crash section, sometimes theaters are not available. In smaller setups, the challenge is different, because there are many places where there isn't a blood bank and the next blood bank is about a 3-hour drive away. There are places where the anesthetist and the neonatologist often also work in the public sector, and therefore at times when they are on duty in the public sector and sometimes at night, or if they come from another town, then they are not available after 3 or 4 p.m. So transfer of women in these times takes time. And the challenge for many obstetricians, especially the younger, less established ones, is when they talk about guidance and what is right, patients go away saying others are not doing the same. And this is a fairly damning statement from a hospital chief executive that it is not part of the Indian medical environment right now to critically analyze outcomes and compare it to standards, meaning that audits are not happening and there isn't a drive to maintain these standards. This, of course, is changing, but the change is happening in small pockets, and hopefully those little drops will drive to increase the number of places where this is happening. What about the woman? Is the perception of risk by women different? And we've had women in our practice tell us, Doc, you're willing to take the risk and wait, but not others. So labor and delivery is perceived somehow as being risky. And in India, we also have that rather unique challenge of an auspicious day, where people tell us that the day after is not a good day, Doc. You can induce me tomorrow, but I don't want to deliver day after. If you can guarantee that's going to be normal, that's fine. But if you think there's a chance of a section, why not do it at a time where the baby will have a good future? Because this time and date is very auspicious. We've had families that question saying she's been in so much pain and then you've done a section and now the baby's in the NICU. We are not happy. You could have just bailed out and done a section. It's safer, no? And of course, we have women who are scared about the pain and women who feel that they rather be in control. This perception of risk is also there by the obstetrician. And this is a direct reflection of training and practices, because there is poor skill training in assisted vaginal deliveries. People have forgotten how to do external cephalic version on deliver breaches, and CTG interpretation is far below par. And this is what has led to the cesarean section becoming an epidemic in India of sorts, and both in the private and in the public sector, but clearly more in the private sector than in the public sector, with nearly a 400% increase across a decade. So what then are the solutions while we are all troubled by the problem? The first, I believe, is introspection and audit, and looking at the 4 categories of Robsons where we can separate the potentially unnecessary sections, looking into the indications within these groups so that we can audit and see how we can change it, to introduce obstetric quality assessment in units, where while we are all trying to get our NABH entry level and full accreditations, none of those quality actually look at obstetric quality, including section rates. We must strive to reduce the primary cesarean section rate and encourage TOLAC. Now, some of the hospitals do put out their rates voluntarily, and because of this, there are a lot more women coming in seeking vaginal birth, and these are ways in which we can confidently put out the rates ourselves. Systemic changes are extremely important, because strengthening the infrastructure is vital. Introducing obstetric nursing and midwifery will make a huge difference, because then the obstetrician is not solely responsible for monitoring the woman, and fatigue and time constraints are not going to be reasons to take a shortcut and deliver a woman earlier. Larger chains and hospitals need to focus on quality and standards over volume. And obstetric training certainly has to strengthen training in assisted vaginal delivery. We've had young doctors who have completed their postgraduate training come to work with us, having never done an instrumental delivery before. And the first time they do it is under our watch in a private setup. CTG training modules, again, and ongoing skill updating is extremely important to give obstetricians the confidence to monitor and allow women to labor. All this is fine in theory, but is it implementable? Now, this is an interesting article about how a corporate center in Delhi implemented this change, how they started off with a cesarean section rate of about 79%, put in quality training initiatives, audits and monthly presentations, group practices, introduced antenatal classes, introduced a group practice concept to the women, and lastly, introduced a trial of SCAR. And they have shown a dramatic reduction over a decade of not just the overall cesarean section rate and the cesarean section rate in primips, but an increase in the vaginal birth rate and a significant decrease in elective deliveries under 39 weeks. It's important that we educate and empower women, because the general public perception that sections are somehow safer has to change. The fact that laboring can be done in a safe manner, that it will take time, that we have to be patient, can be communicated in the antenatal education classes. We have to empower women to make the right choices. And unfortunately, in India, it means that we include family in the discussion, because it is so common to see a woman look up to her husband to make a choice even about pain relief in labor, and to decide on induction dates or any aspect regarding delivery. So we cannot ignore the family, because it is them who influence the woman often, and the decision-making power is never with her alone. Enforcement will come into rule if we do not take action, and this is what happened about 2 years ago with suspension orders being issued in Telangana and parts of Tamil Nadu, and a demand for display of cesarean section rates being made by Maneka Gandhi, amongst others. Now, if we don't take action, then this is what will become the norm, and therefore it is time to act now. It is already maybe too late, but it is possible to make those changes if we take this as an important agenda in our hands. Clearly, it is not going to happen overnight, because it is not as simple as just charge the same for a vaginal delivery as a section and the rates will change, because it is money that is driving private obstetricians to do sections. It is not just about money. It is about having a system that will allow us to deliver vaginally, to practice obstetrics the way it is meant to be. It requires a multi-pronged, dedicated effort and a commitment from all fronts. And it is not just about that birth or that single section, because we are seeing an alarming increase in placental adherence, especially in the South. And that is something that is completely iatrogenic. We are also understanding that the implications of an elective cesarean section over a vaginal birth is not just about that delivery. It's about the impact on the baby, its microbiome, and its future metabolic health. So the implication of an increasing cesarean section rate is also a long-term impact on the mother and the baby. So a dedicated effort by the obstetrician, taking the woman along with her, the hospitals providing the support, and the government providing a conducive environment and infrastructural support will all go a long way in ensuring that in the private sector, we are able to reduce our cesarean section rate. And together, we can certainly change the narrative. Thank you.